Welcome to Mastering Public Health. This episode covers Chapter 2, Health Behavior Change Theories and Models. The goal is to understand how theory explains behavior and how models turn theory into practical program design, implementation, and evaluation. Educational summary based on Introduction to Health Promotion, 2nd edition, Chapter 2 by Maura Stevenson. All rights to the original text belong to the author and publisher. Produced by Mastering Public Health. Learning objectives. By the end of this chapter, you should be able to define core theory terms, describe 4 cornerstone theories of behavior change, identify major constructs, especially self-efficacy, explain how stages, beliefs, and intentions guide interventions, and apply these ideas to planning, implementation, and evaluation. Section 1. Why theory and models matter. The first point is that behavior is complex, and individual choices are shaped by personal, social, and environmental forces. Theory offers a general explanation for why people act or do not act to maintain health. The second point is that models translate theory into systematic steps for program planning, implementation, and evaluation. A third point is the chain of abstraction. Theories include concepts refined into constructs, which become measurable variables for assessment. 2. Social Cognitive Theory, SCT. The first theory is Social Cognitive Theory, developed by Albert Bandura. SCT emphasizes that people learn through observing others and that behavior is shaped by a continual interaction between person, behavior, and environment, a dynamic called reciprocal determinism. The most important construct in SCT is perceived self-efficacy, which is the belief that one can successfully perform the behavior under typical and challenging circumstances. Self-efficacy is strengthened through mastery experiences, observational learning or modeling, and verbal persuasion and support. When self-efficacy is high, people set goals, initiate action, and persist in the face of barriers. SCT also highlights knowledge of risks and benefits, outcome expectations that can be physical or social, personal health goals that are short-term and attainable, and the balance between facilitators and impediments in the environment. Together, these constructs guide how we design skill building, modeling, and environmental supports in health programs. Section 3. Transtheoretical Model, TTM. The second theory is the Transtheoretical Model, originated by Prochaska, Diclement, and Norcross. TTM views change as a process that moves through predictable stages of readiness. The 6 stages are pre-contemplation, contemplation, preparation, action, maintenance, and termination. Each stage reflects a specific mindset and risk of relapse. Interventions should be tailored to the current stage and use processes of change to help people progress. These processes include experiential and cognitive strategies such as consciousness raising and environmental reevaluation, and behavioral strategies such as reinforcement management and stimulus control. 2 cross-cutting ideas are decisional balance, weighing pros and cons, and self-efficacy, which increases across stages as people accumulate successful experiences. Section 4. Health Belief Model, HBM. The third theory is the Health Belief Model, a value expectancy framework developed within the U.S. Public Health Service. HBM proposes that behavior depends on the value placed on health outcomes and the expectation that a specific action will achieve those outcomes. Core constructs include perceived susceptibility, perceived severity, and their combination as perceived threat. People also evaluate perceived benefits of action and perceived barriers that might impede action. Cues to action trigger the behavior, while self-efficacy supports initiation and maintenance. In practice, HBM suggests clarifying the risk, making the threat and benefits personally relevant, lowering barriers such as cost or access, and building confidence to act. Section 5. Theory of Planned Behavior, TPB. The fourth theory is the theory of planned behavior, which extends the theory of reasoned action. TPB predicts behavioral intention, which is the immediate antecedent of behavior under volitional control. Intention is shaped by 3 primary constructs: attitude toward the behavior, subjective norm, and perceived behavioral control. Perceived control reflects both internal factors such as knowledge and skills and external factors such as time, opportunity, or reliance on others. When attitudes are favorable, social approval is expected and control is high intention and thus behavior is more likely. Section 6: Historical Perspective and Integration. Early campaigns in the 1980s often relied on HPM and TRA-TPB to raise awareness and shift beliefs about risk and benefit. Over time, SCT broadened the focus to include modeling, skills, and environmental determinants. TTM added a temporal dimension of readiness and relapse prevention, enabling tailored messaging at the individual level and segmentation at the population level. The unifying construct across these frameworks is self-efficacy. Effective programs select and integrate elements from multiple theories to fit the population, setting, and behavior. Section 7: From Theory to Practice. Translating theory into programs follows 3 steps. First is diagnosis. Identify the behavior, its stage of readiness, salient beliefs, social influences, skills, and environmental barriers. Second is design. Choose strategies aligned to constructs, such as efficacy building practice, stage matched prompts, normative messaging, barrier reduction, and environmental change. Third is evaluation. Measure the variables linked to the constructs you targeted and assess whether the hypothesized pathway changed as planned. A practical rule is to let the dominant constraint determine priority. If readiness is low, lead with TTM style awareness and prose. If confidence and skills are low, lead with SCT mastery and modeling. If beliefs about susceptibility or severity are inaccurate, lead with HPM reframing. If social pressure or control is the barrier, use TPB-aligned strategies to shift norms and increase control. Section 8: Common Pitfalls. There are 3 frequent errors. The first is using a favorite curriculum without diagnosing which constructs actually limit change in this population. The second is mixing tactics from multiple theories without a coherent logic model. The third is measuring only distal outcomes while ignoring the mediators you aim to change, such as self-efficacy, perceived barriers, or perceived control. Avoid these by documenting your theory of change and aligning measures to constructs. Conclusion: the key idea is that theory explains behavior and models organize action. A second idea is that self-efficacy is central across frameworks. A third idea is that selecting and tailoring constructs to the population and setting improves effectiveness and sustainability. In the next chapter, we will connect these theories to program planning models and evaluation pathways in more detail. Educational video is based on Introduction to Health Promotion, 2nd edition, Chapter 2. All rights to the original text belong to the author and publisher. Produced by Mastering Public Health.